Dear students, today the topic which we will discuss is about liver, its functions and the different type of liver function tests which are available. So to introduce you to liver. Liver is the largest organ in the human body. It weighs around 1200 to 1600 grams and has a width of around 15 centimeters. It is located in the right upper quadrant of the abdomen. It is a wedge-shaped gland which has two anatomical lobes, the right and the left. The lobes are divided anteriorly by the falciform ligament, inferiorly by the fissure of ligamentum teres, and posteriorly by the fissure of ligamentum venosum. The vascular supply of the liver is from the hepatic artery and the portal vein. So to briefly enumerate the main function of liver, the first one, metabolism of carbohydrates. The liver is involved in glycogenesis, glycogenolysis and gluconeogenesis. The second one is protein metabolism. The liver is responsible for protein synthesis as well as degradation. The third one, production of clotting factors. They produce coagulation factors 1, 2, 5, 7, 8, 9, 10, 11 and 12, as well as protein C, protein S and antithrombin. The fourth one, the liver is a major site for production of thrombopoietin which regulates platelet production. The fifth, lipid metabolism. It is responsible for cholesterol synthesis and lipogenesis. The sixth one, role in digestion. It produces bile and secretes them for fat emulsification and vitamin K absorption. The seventh, hormone production. It produces insulin-like growth factor 1 which is responsible for growth. Number 8, liver is responsible for degradation of insulin and other hormones. Number 9, the liver is also responsible for bilirubin conjugation via glucuronidation. Number 10, liver is also responsible for degrading or breaking down of toxic wastes. Number 11, they also store vitamin A, D, E, K, B12, copper and iron. Number 12, immunological effects. It contains many immunological active cells. Number 13, production of bilirubin responsible for maintaining oncotic pressure. Number 14, it also produces angiotensinogen which is responsible for raising blood pressure. Number 15, they also produces catalases which helps break down hydrogen peroxide. Number 16, the liver's oxidative capacity is responsible for drug metabolism. Now, to name a few of the liver function tests. These are tests to assess the functional capacity of the liver and also to aid in the diagnosis, accurate treatment and prognosis of liver diseases. Many types of tests are available. The following table summarizes the available tests. The first table, test for manufacture and excretion of bile. So in the test, to estimate bilirubin, we measure serum bilirubin. The significance of measuring serum bilirubin is, it is seen increased in hepatocellular, obstructive and hemolytic diseases as also in Gilbert's diseases. Estimating bilirubin level in feces, this is absent in biliary obstruction. In urine, conjugated bilirubinuria is seen in patients of hepatitis. Urobilinogen levels may be seen increased in hepatocellular and hemolytic diseases while it is absent in biliary obstruction. Bile salts estimation, it is seen increased in serum and detectable in urine in cholestasis. Now coming to the second table, which is serum enzyme assays. Here we measure alkaline phosphatase, the significance of which is increased levels are seen in hepatobiliary diseases, highest in biliary obstruction, bone diseases and pregnancy. Gamma glutamyl transpeptidases. This rises parallels alkaline phosphatase but is specific for hepatobiliary diseases. The next enzymes, transaminases. These are the SGOT and SGPT. SGOT seen increase in tissue injury to liver and to other tissues as well. Example, in myocardial infarction. SGPT increase is fairly specific for liver cell injury. Other enzymes we have 5-nucleotidase, rises parallels alkaline phosphatase, but is more specific for diseases of hepatic origin. Lactic dehydrogenase increased in tumors involving the liver. And cholinesterase decreased in hepatocellular diseases and in malnutrition. The third table summarizes tests for metabolic functions. Here we see amino acids and protein metabolism. Serum proteins, which involves total serum protein, albumin globulin ratio, and protein electrophoresis. Hypoalbuminemia is significantly seen in hepatocellular diseases. Hyperalbuminemia is seen in cirrhosis and chronic active hepatitis. Immunoglobulins, there are non-specific alterations in IgA, IgG, and IgM. Clotting factors, prothrombin time and partial thromboplastin time are prolonged in patients with hepatocellular diseases. Serum ammonia, increased in cirrhosis, acute fulminant hepatitis, and hepatic encephalopathy. Aminoaciduria is also seen in fulminant hepatitis. Lipids and lipoprotein metabolism, both lipids, which are total cholesterol, triglycerides, and lipoprotein fractions, are measured. They are increased in cholestasis, decreased in acute and chronic diffuse liver diseases, and in malnutrition. Carbohydrate metabolism, which is blood glucose and glucose tolerance test, they are decreased in hepatic necrosis. Now coming to the other table, immunological tests. Non-specific immunological reactions. So the smooth muscle antibody is seen in hepatic necrosis. Mitochondrial antibody is seen in primary biliary cirrhosis. Antinuclear antibody and LE cell test are seen in chronic active hepatitis. In hepatitis B, we measure the antibodies to hepatitis B, and in amoebic liver disease, we have amoebic antibodies. Other ancillary diagnostic tests, these are ultrasound examination, fine needle aspiration cytology, and or percutaneous liver biopsy. Ultrasound examination helps us in cholestasis of various etiologies, space occupying lesions, ultrasound guided liver biopsy or FNAC. FNAC and liver biopsy, we use it for unknown causes of hepatocellular diseases, hepatosplenomegaly, long-standing hepatitis, space occupying lesions of the liver. The tests to assess the different anatomical and functional components of liver are briefly described as follows. The first one, test for bile pigment metabolism in jaundice. It involves measuring the serum bilirubin and Van den Berg reaction. Van den Berg reaction is done to differentiate hemolytic and obstructive jaundice. In hemolytic jaundice, an indirect Van den Berg reaction occurs, which is due to increased free bilirubin, while a direct Van den Berg reaction occurs in obstructive jaundice, which is due to increased conjugated bilirubin. The next, icteric index. This test measures the degree of jaundice by measuring the intensity of yellow color of the serum. Serum is diluted with normal saline until it matches the color of 1 in 10,000 solution of potassium dichromate. The dilution factor is called icteric index. Normal value is between 4 to 6 units. In latent jaundice, values may be between 3 to 14 units. Values more than 15 units are seen in clinical jaundice. Urine bilirubin. The presence of bilirubin are tested by Schlesinger's test, Fauchet's test, and Gemelin's test. Now coming to fecal stercobilinogen. Stercobilinogen values of 10 to 150 mg per day is seen in stone obstruction, while values may be low in malignancy, which is around 0 to 5 mg per day. Congenital hyperbilirubinemia. Congenital hyperbilirubinemia are seen in Gilbert syndrome, Lucy-Driscoll syndrome, Dubin-Johnson syndrome, and Crigler-Najjar syndrome. Then we have the test for carbohydrate metabolism. We have the galactose tolerance test, After an overnight fast, a fasting sample is taken. Thereafter, the individual is given 40 grams of galactose in 300 ml of water. Blood sample for estimation of galactose are taken at 30 minutes interval for 2 hours. The normal blood galactose level is 0 to 160 mg per 100 ml. In infective and toxic hepatitis and cirrhosis of liver, values of up to 500 mg per 100 ml of blood is seen. Now coming to fructose tolerance test. After an overnight fast, a fasting blood sample is taken. Thereafter, the individual is given 50 grams of fructose in 300 ml of water. Blood sample for estimation of glucose are taken at 30-minute intervals for 2 hours. Normally, the highest blood glucose levels does not exceed the fasting level by more than 30 mg per 100 ml. Values more than 150 mg per 100 ml are found in infective hepatitis. This test is less sensitive than galactose tolerance test. The third, test for plasma protein concentration. Plasma albumin, globulin and fibrinogen concentration. Electrophoretic separation of plasma proteins by paper electrophoresis is done to determine the percentages of plasma proteins. The normal values are as follows. Albumin constitutes about 55.5%, globulin 44.8%, albumin globulin ratio 1.23%, alpha-1 globulin constitutes about 5.3%, alpha-2 globulin constitutes about 8.7%, beta globulin constitutes about 13.4%, gamma globulin constitutes about 11% and fibrinogen 6.5%. In chronic active hepatitis, gamma globulin is increased. Hypoalbumin is seen in cirrhosis of liver. Fibrinogen levels are decreased in hepatic necrosis. So now coming to the flocculation tests. This involves thymol turbidity test, which is done to measure turbidity against standards containing 10, 20, 30 up to 100 mg per 100 ml of protein when serum is mixed with a buffered solution of thymol. A turbidity equal to that of 10 mg protein standard is taken as 1 unit by McLagan. A value of 0 to 4 units are considered normal. Elevated levels may be seen usually in infective hepatitis. Other tests are serum colloidal gold test and zinc sulfate tests. There are also tests to determine amino acids in blood and urine. Now coming to tests for lipid metabolism. We measure serum total, free and ester cholesterols along with fecal fat. Now the fifth, test for detoxifying functions, that is excretion of foreign substances. We have the hippuric acid synthesis test. In this test, the patient empties the bladder and drinks sodium benzoate in 200 ml of water. 4 hours urine collection is done. Liver detoxifies benzoic acid by forming purified acid after reacting with glycine. A normal individual excretes 60% of benzoic acid, which is about 4.5 grams. Smaller quantities are excreted in acute and chronic liver diseases. Next, we have the Bromsulphthalein test. In this test, 5 mg per kg body weight of Bromsulphthalein dye is injected. Normal subjects after injection retains less than 10% of dye in 30 minutes and 7% in 45 minutes. At 60%, no dye is retained. In hepatic dysfunction, up to 50% of dye may be retained at the end of 45 minutes. The seventh, test for coagulation of blood, which is the prothrombin time determination. The eighth, we have tests for serum enzymes derived from the liver. The first one being alkaline phosphatases, transaminases, isocitrate dehydrogenase, pseudocholinesterase and 5 nucleotidase. The ninth, we have test for conversion of ammonia to urea. Of the subtype, we have blood ammonia determination. The normal level of blood ammonia is between 40 to 75 mg of ammonia nitrogen per 100 mils. In cirrhosis of liver, the values may be increased to more than 250 milligram per 100 mils. Next we have determination of glutamine in cerebrospinal fluid. Glutamine in cerebrospinal fluid is normally between 6 to 14 milligram per 100 mils. Values ranging from 16 to 31 milligram per 100 mils are seen in cirrhosis, while hepatic coma may show values from 30 to 54 milligram per 100 ml. So these are the few of the liver function tests which are available to us. Now to conclude, liver is one of the largest organs in the human body. It has both catabolic and anabolic functions. A variety of tests are available to assess the functional capacity of liver. These tests, in correlation with the clinical presentation, guides us in early diagnosis and management of liver diseases. Thank you.